Yeah, no, I that's a really powerful thing, and I have wondered about that. And you could transplant people with HIV with, some sort of bone marrow that would not be able to be infected by the HIV.
Hello, 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 and welcome to eShadowing. Welcome, welcome. As you come in, say hello. Let me know where you are watching from. Let me know potentially what specialty you may be interested in, or what specialty you may want to see here on eShadowing. I see Dr. Crane is here. Let me promote her to panelist. We'll get her on. We are excited today to have Dr. Genevieve Crane on to talk
Hi.
about. Hello there.
Hi.
How are you?
Thanks so much for having me. I'm good. Yeah.
I'm excited to have you. We're going to talk some hematopathology today. Talk about the path world, bust some myths about those pathologists hanging out in the basement. It looks nice and bright and shiny where you are. Those may be fluorescent lights.
There
Or
may
maybe
be some
they're
fluorescent
windows.
lights. Yeah. No, I have a small window actually in here. It's pretty. We're on the third floor, so
Nice.
it's nice. It's nice. Yeah.
Awesome. Awesome. Well, I'm excited to have a chat with you. I know you prepared a presentation, so we can either dive into the presentation or we can start with some chit chat and see where we go from there.
We can start with some chit chat, I guess, if you want. I mean, I don't want to torture people with PowerPoint, but never bad to have. I think.
Yeah, let's do it. So let's start off. I want to find out when you first realized you wanted to be a pathologist.
Well, that's a long story. But I always knew I wanted to be in medicine and kind of in medical research and kind of advancing our knowledge of diseases that are currently undertreated. Like that was very early on as a young child.
Undertreated diseases. What exposed you to that? Did you have family members with some
Family
rare
members
disease?
with yeah.
Yeah, it's always the answer. And people are like, I don't want to write about that, or I don't want to talk about that. That's cliche. I'm like, but that's your story.
That's
That's
my
what
story. Yeah,
happened.
no, I get like emotional, so that's why I don't like to talk about it, I guess,
Yeah.
more so than anything. But
Yeah, I have a child with a rare disease, and so I'm all about science and research and finding that stuff out.
yeah, and I think there's so much that we've learned just in my lifetime, so many advances that we've made. But there continue to be so many things that are undertreated. But yeah, it was
Yeah.
my father who was sick. And
Mm.
so
Okay.
he had multiple sclerosis, a very aggressive course.
Yeah. And nowadays, right? There are amazing drugs for MS out
They're
there now.
amazing drugs. Yeah, and yeah, another family member was diagnosed with it subsequently to that, and he's done extremely well.
Yeah.
So that's,
I
but
was
yeah,
on
my
some of
dad
those
was
drugs for
like,
a little bit. They thought I had MS for a little while. I have some spinal cord lesions, and they're like,
oh
"Oh, I think
no,
you have MS." And they're like, after a while, they're like, "Yeah, this isn't MS. You just have some spinal cord lesions." I'm like, "Okay,
I don't know.
whatever you say, doc."
Whatever. We're not avoid imaging at all costs. I guess we know what you're
Yeah,
gonna find in there.
it's
Yeah.
phenomenal. Neurology has obviously been
Mhm.
a big recipient of medications these days, MS being one of those big ones. So yeah, I had a friend recently, her father just passed, and he had very bad MS. And you think about, right, just whether it's MS or the polio vaccine, thinking about all the people who suffered with polio, and they're like,
My dad had a
science
very
is
severe case
cool.
of polio and was paralyzed and recovered, but that's what I
Yeah.
wondered that it was related to that polio at some point. It wasn't even
Yeah.
it wasn't the vaccine, it was the real deal.
Yeah.
Yeah,
That's crazy.
it
Well,
is crazy. But yeah, no, here and but the thing is it's a very slow, and a lot of the diseases that we deal with are very slow and progressive, and you think, well, but there's something I could do to just, better understand this process or halt the process.
yep,
What an impact that would have on families. And so yeah,
it's huge.
it's
Um,
huge.
well, let's talk about that, right? MS. They think potentially they found a link to was it EBV? Is that the
I mean,
the
there's
link
kind
that
of
they
certainly
found?
been, and EBV is certainly, I mean, I think like I didn't end up in neurology, but certainly thinking about inflammatory disorders as a
Yeah,
hematopathologist and viral driven processes and just kind of the ubiquitous nature of EBV.
yeah.
And certainly I think some people may have a different response than others. And yeah, I think there certainly have been some links with that. It's very intriguing.
So when you think about that kind of stuff as a pathologist with all the training that you have, and then you see this little thing that's come on the world stage, COVID, and we have long COVID and people suffering, like, do you ever like think about, just from a scientific perspective, like in 20 years, like we're going to have these new things that we're going to look back and go, oh yeah, it's because of your COVID infection that you have this issue now.
Yeah, I mean, I think there's going to be a huge number of different effects from COVID that we're just learning now. And I think the vaccines have also been very interesting with kind of different mechanism and the inflammation, maybe with other cell types producing these proteins. Are we getting kind of a response from the vaccine that's causing some effect that we don't realize? I'll probably be silenced if I say anything about it. I mean, the vaccines have been an incredible thing to have,
Yeah.
and certainly to prevent having COVID is a major advance, because we don't know the long-term effects of COVID either, with these kind of long, kind of certainly all these herpes viruses just hang out in our body forever and remain latent. And to some extent, this COVID may be just hanging out, or different forms of it, or different things. So yeah, I don't know. I think we're gonna have, unfortunately, we're like, oh, the pandemic is over, but I feel like we don't even know. I mean, it's just started in terms of all the repercussions for this and the changes to how we live our lives. I mean, I think it's at least the acute portion of it is over, and we're moving forward. But I think we're
Yeah.
just at the tip of the iceberg of really understanding this. And I don't know, I think it has raised a lot of public awareness of viral illnesses and kind of thinking about public health. And I think it will in some ways be a good thing in terms of those aspects, but
Yeah.
I don't know. It's been
Although
rough
I
for years.
still it blows my mind. Number one, still seeing like snotty kids at the store without masks on. I'm like, haven't we learned, like, and then like, just to TMI here, like I was in a public restroom the other day at a restaurant, and the dude like next to me walks right out without washing his hands. I'm like, are we really still not washing hands after using the restroom? Like, come on, people. We know how germs spread.
My favorite is like, well, it's not COVID, so I just like get not everywhere. It's like, okay, but all right.
Yeah,
It's not
it
just
amazes me.
COVID, it's
Yeah.
everything. Like, let's wash our hands. Like, yeah. It's kind of
Yes.
funny.
Ooh, Hadley. Yes. So hematopathology. Um,
Mhm.
uh, why hematopathology?
Yeah, I mean, I think I took it, as I said, it's a little bit of circuitous route here. I did do MD PhD and got interested in stem cells, which certainly that ultimately led me in part towards hematopathology, because I was working on neural-crest stem cells, which obviously they give rise to a variety of things within the body.
Yeah.
Part of melanocytes in the skin and your enteric nervous system, peripheral nervous system, but they're largely gone in adults. So when you're thinking of stem cells, you're thinking the hematopoietic system is one of the areas where we really have, as well as like skin, epithelial tissues, where you have ongoing critical need for stem cells.
Mhm.
And a lot of the disorders that we deal with, at least on the and kind of on our bone marrow side, are actually stem cell disorders. So I think that got me really interested, that tie in to my research and to these kind of cells with huge potential that go awry.
Yeah.
And kind of thinking about mechanisms, and a lot of times are mechanisms that kind of tell you a little bit about what that cell does normally. Like, so it's not just like some random mutation, it's mutation that kind of enhances in some ways that ability to function normally, but it just gets out of hand.
Mhm.
And so you're learning about kind of the basic way that human physiology works, but as well like how that goes awry, and then thinking about, because you're down to like what cells causing trouble, what the mutations are, you're thinking about, okay, now I can manipulate this system, like maybe there's some way I could change this. And so to me, I think hematopathology was exciting because it was the most tractable, because I think it's in advance of some areas where we're kind of more just looking at the tissue basis, and we don't really know where things have arisen from and different things like that. And there's not as much of a molecular or cellular basis to it. So
Yeah.
I think that's what got me into the heme path side.
Okay. So potentially more tangible effects that you could see, maybe a little bit faster effects. Bigger dopamine responses from the work that you're getting. Like, oh, I see something.
I guess so. Yeah, you see something and you have a lot of ways to kind of tease it out that are actually even part of standard practice, I guess. Like, yeah.
What stem cells have been the talk of the town for, it seems like maybe going on a couple decades now.
That's about when I finished my PhD. I was in the highlight. Yeah, I guess. Yeah. In the heyday, but continues.
Are we going to see the fruits of all this labor of like the magical like MS, right? MS is one of those where there are some countries that are doing stem cell therapy for MS, supposedly with the hope that it's going to go in and fix those lesions. Are we going to get to the place where it's like once a month, everyone's going to get their stem cell shot and it's just going to go fix whatever's wrong in the body?
Well, I mean, I guess I think there's certainly that potential. I mean, I was doing some postdoctoral work when the induced pluripotent stem cell work came out, and there's initial belief like, oh, this has got to be a lie. There's no way that's going to work. But it's pretty extraordinary that we could take our own cells and, take them backwards and they could become any cell in the body.
Yeah.
So certainly there's that potential, but how do you say, okay, this is what you're going to make cells and you're going to integrate appropriately into the body in a way that's functional, especially the nervous system. Like you've got to get it, because normally things are going to, they migrate out during development, they form these close associations and they develop all these functional ways of integrating. And so I don't know, that's going to be a bigger challenge. But I think in some areas like tissue engineering, I mean, there's been huge advances of that even before I really started with, growing cartilage, growing bone, these sort of tissues you can grow from mesenchymal stem cells or other cells. And it seems like hematopoiesis also, we probably can get further and rather than using our own cells to do bone marrow transplants one day that are purified rather than using allogeneic cells when you get the whole risk of graft versus host disease. I mean, those things seem pretty tractable because we already know how to get those cells to engraft to a certain extent. The brain seems like another, getting things into the brain, I don't know.
That stupid blood-brain barrier.
And the brain is so, I mean, I was working on neurocrest, as I mentioned, neurocrest stem cells, and I got, pretty interested in peripheral nervous system regeneration. And I found that there were actually a small number of neurocrest stem cells that would persist. And they had, they had a kind of a strong bias, but they remained still multipotent. And so the potential of regenerating injured nerves after an accident or, certainly glial cells and things already regenerate, but I don't know. It's pretty tough. And in Hirschsprung's disease was one thing I studied where we found, you actually didn't lose. In a lot of the cases, you didn't, like the original idea was you had kind of stem cells migrating down the gut, and then they just would kind of run out before they got to the hind gut.
Just ran out of fuel. Like,
I'm tired.
I'm gonna rest here.
I'm just gonna differentiate right here.
Sorry, anus. Yeah.
And so then you just would, but they found that it was actually just kind of a migration problem, a signaling problem. Like they just were like, what? Oh, I was supposed to keep going. I just thought I was here,
That's not what the GPS told me.
Yeah. So it's kind of, but even with that though, it's like to be able to then, get those cells to then migrate through a more mature tissue and differentiate appropriately. It's a big ask. But I think in terms of, like a gut transplants and things like that, there's a possibility, okay, these cells do exist. If this material or this, you made like some sort of artificial organ or something like this, you could probably implant or include some sort of neural crest stem cell that would then give rise to the appropriate enteric nervous system within that to make it a functional piece of bowel. Like, I think that's possible.
Yeah.
But all these things, like we were thinking about it 20 years ago, and now 20 years have gone by, and it seems like, well,
well,
no,
yeah.
did we get very far? Not yet, but
Okay. Wait, and how much do you think, and then we can jump into your PowerPoint slide. How much with the rise of gene editing tools, right? We have gene editing tools kind of on the rise. We have the stem cell kind of stuff that's been around for a little bit. Like, how much are those two fields integrating now to go, oh, well, we know, I think it's in Europe, there's some sort of gene mutation that we know of that makes people immune, I want to say, to HIV. Like, they're just immune to HIV. And it's like, we know what this gene is, so let's just go ahead and edit this gene and give it to HIV people who have HIV.
Yeah, to make it so that certain cells can't be infected.
Yeah.
Yeah, no, I that's a really powerful thing, and I have wondered about that. And you could transplant people with HIV with, some sort of bone marrow that would not be able to be infected by the HIV. Right now, I guess they don't recommend doing that because of the risks of, transplantation. I'm not an expert in this aspect, I will say. So if I'm misspeaking, I guess my Twitter
but
blow
just
up
in
with lots of
general, like
things.
those two fields
but yeah,
being
no, but I
married.
think, in terms of having your own bone marrow, if it were modified to not be able to then be infected by the HIV, that seems like it'd be an extraordinary opportunity. So I don't know. I think that's, I'm sure that's cooking. I'm sure it's cooking somewhere. So those things are definitely feasible. So I think we have made some major advances, and I think, like you say, with the gene editing and our ability to kind of manipulate differentiation of cells and harvest different cells, I think there's exciting times ahead. Yeah.
Exciting times. All right. Let's jump into your PowerPoint and
PowerPoint.
Then yeah.
Okay, let me see if I can. Let's see if I do this. But then we have to do screen share. Which is apps. We have a lot of options. I guess I don't use this particular thing under view. No.
So if you click on that little green screen share button.
Oh yeah. For some reason, with it being green, I'm like looking at everything but that. All right. Let's see. So this is, I made this little thing. So talking about kind of, I don't know, it's kind of a very subspecialized area that I'm in. And so how do you end up getting here? Well, that's a good question. Kind of a long circuitous route. And sometimes it looks like you actually have had quite a few pathologists on. I was excited to see you had Judy Melanek on, who's like one of my heroes.
I love Judy. Yeah.
She's so amazing. I've read all her books, and my son loves her books. We read them out loud. And
we've met a few times at different conferences, and I've had her on various places. Yeah, she's awesome. Her and her husband are both awesome.
They're both awesome. Yeah. No, I got to meet them in person at their book signing at one point too. It was really, I think they really do a lot of great things for the field too, to increase interest in pathology and awareness of pathology. And
do you know she ran away to New Zealand?
I had seen that. I wanted to join her. I was like, that sounds good. That sounds nice. I don't know. So I mean, that's one aspect of pathology, and kind of a lot of people think about it, the autopsy and forensic aspects, but really we're kind of just like behind the scenes with everything. In medicine, kind of looking at all the blood, body fluids, all these tissues that are being removed for diagnostic purposes, hernia sacs. Sometimes I made a primary diagnosis of acute leukemia actually on a hernia sac one time. I mean, so there's all these things, or if you have a pancreatic tumor, kind of what is it? Are the margins clean? There's some pathologists behind, as well as like a whole range of staff processing this stuff and making sure that we've got the right diagnosis for the patient. And we're constantly in contact with the clinical team, kind of like, because a lot of, especially one other thing I like about hematopathology, it's not just like, for example, like prostate cancer, you're like, okay, it's a prostate. You don't really need to know a lot else about the patient to make a diagnosis of prostate cancer. But with hematopathology, kind of their age, their underlying disease states, any medications that they're on, all these things really go into making the correct diagnosis and kind of figuring out the prognosis of different things. And so we're always in very close contact with the clinical team on the pathology side. And it kind of ranges in different fields depending on what you're looking at. But the field has kind of blown up lately because we just know a lot more, like you mentioned, with all the genetics and everything. And so kind of knowing what is the molecular background, does this person have a predisposition syndrome to certain types of tumors? If so, maybe they're going to benefit more from one type of therapy or another. Maybe we need to let their relatives know to undergo screening, etc. And then also, because our treatments are actually better, kind of figuring out, it's not really good enough to kind of just necessarily just look at a piece of tissue and be like, well, I don't see any tumor anymore. Like, we need kind of more elaborate methods to say we've really wiped out this tumor, or else we should continue therapy or maybe do a different therapy. So a lot of stuff that we do is with this minimal residual therapy, minimal residual disease testing.
It's always been a pet peeve of mine when doctors are like, you're cancer free. I'm like, you sure about that? Like, do you know, like, one tiny little cell that's hiding there?
Yeah, so that's what we find. I mean, I think this is being done looking at 0.01 or 0.001%, and hematopathology really lends itself to that, because I mean, the good and the bad of it, it's like everywhere. So, certain leukemias and things, they end up, in the blood, in the bone marrow, they could be in a variety of tissues. So, you can find those all over the place. And so that's kind of what we do. And these are all people kind of sitting by themselves, I guess, like looking at laboratory equipment, or this is me in my office, except for this guy's kind of dressed up. He looks nice. I don't know. You don't have to dress up as much, but you could. Yeah, so it's like, but this is kind of more what it's like. I found this picture online from Loyola. Like, I mean, usually we have these multi-headed scopes. We have, we have trainees that we're working with all the time. We're discussing cases. We have more senior colleagues, more junior colleagues. People have one expertise or another. So we're always showing each other cases. We're always like, you wake up in the night, you have an idea. You're like, it's like, you don't always have to know what something is right away. It's ideal, I guess. But, sometimes it's really a puzzle, and it takes you a long time to figure it out. And so it's nice to have a group and being like, hey, you know what? I actually saw something like this, like 4 or 5 years ago. Maybe you should look into, this particular marker or something. And we have a bunch of different tests that we can do. And because it's like on a slide, or it's like tissue that's outside of the patient, oftentimes you can even, you can scan it, you can show it to somebody far away, you can send it to someone that has some other weird testing they developed. So it's kind of, I think it's very fascinating. Like, it's not just like make a decision, run, stop the bleeding. It's like, it's a different aspect where you're just like, oh, you know what? It might be this. And then you just start investigating that. And a lot of diagnoses, you don't necessarily need the diagnosis that minute. Some things you do for sure. But other things that there is time, a matter of days, or even, a week or two to kind of solve things and really get patients the right information and get them the right therapy.
Yeah. What do you think is the biggest misconception about pathology, or maybe more specifically hematopathology, that maybe residents have, med students have?
Yeah, I mean, I think several misconceptions. I mean, certainly when I was in training, there was a perception that it was really not a good field to be in because you weren't going to be able to get a job. But the number of jobs in pathology has really escalated because of all of this important ancillary testing, I guess, that's been done. So that's one misconception. There are a ton of open jobs, and we really need more pathologists. I don't think it's kind of maybe boring. I think people think it's kind of boring and isolated. But I think I mean, certainly, any job can potentially be boring, but I think every case, you're the first person to see what's in there. You've got to make the right diagnosis, and, you're going to be, you're going to be checked. Like, these things are not, you've got to be right every time. And so your pulse is racing a little bit because that someone's going to go to Mayo next week, and then something else, and you're going to hear back if it's not right. And the patient, they're on the line. That radiology, sometimes other people can look at the scan and they can be like, I don't really see it there, or I see it. But from pathology, we kind of keep a hold of our slides, and nobody else really sees them but us. So it's up to you to make the right diagnosis. Make sure you've looked at everything. You didn't miss something. Was there a tumor over here that you didn't see and you thought the whole thing was just reactive? Or, there's certain very indolent forms of a tumor, and maybe you got confused and thought it was something more aggressive, and the patient can end up with completely the wrong therapy. So it's just, I don't know. I think it's kind of exciting to be the first person to see that, to be able to call the clinical team there, and be like, hey, we figured out what it is, this is what you can do for the patient. But yeah, I don't know. I think it's not a bad field in those regards.
Yeah.
And we're not alone. Like there are always people around, people coming by, and like clinical teams looking in the scope with us as well. Like they want to see what we see, and then they give us more information, and then we go, hey, maybe I didn't think of that. Let me go back and try again. So yeah. I don't know, any perceptions you have of pathology that you think
No, just the common ones that I joked about at the beginning about kind of hanging out in the basement and yeah, like dark kind of rooms like radiologists, that you don't get to interact with patients, I think is a big misconception, depending on what kind of pathologist you are and what you do and that kind of stuff. So I think it's important that students understand, right? Pathology is a lot more than maybe what we've perceived in the past.
Yeah, I think it may be even more diverse because people do so many different things and it's getting so subspecialized that, yeah, I think you can really kind of define your career, like whether you're kind of doing blood banking, that's going to be completely different than somebody who's doing more heavy surgical pathology or something else, or doing forensics. It's a completely different world. So yeah, I think it's just very diverse compared to like what many other specialties would be.
Yeah. Okay.
But yeah, it's pretty basic in terms of how to become. It's the same thing. Got to keep going to school till forever, do an undergraduate degree in something, go to medical school. It's a 4-year residency right now. They used to have similar to like anesthesia and other things where you'd have a year where you did kind of a transitional year, but they eliminated that some time ago. So you don't do that. But and programs differ a little bit in terms of the mix between anatomic and clinical, but typically it's about 2 years and 2 years. You can do an anatomic only, which is like your tissue-based autopsy, surgical pathology, and then, or you could do like a clinical. Not very many people do a clinical only residency, but you could, which are on the laboratory testing side and blood banking. A lot of people interested in kind of a research career may do that as well, or do microbiology plus, that kind of thing. And as with the other aspects of medicine, I think there's been a proliferation of fellowships. And so it's like the training goes on and on. But I think because of the subspecialization, like I'm at Cleveland Clinic, which we get a very large number of specimens. We have at least 100 pathologists here, I think. And so,
Wow.
yeah, so we have experts, like sub-experts in everything. But I think that's nice. I mean, I think it's good to have a broad base because you never know kind of what you're going to see. And what you're looking at involves like soft tissue pathology and hematopathology, dermatopathology all cross over because we get lymphomas in the skin and things like that, of course.
Yeah.
But it's good to have some area where you can really call your own and people are going to come to you with those cases, or if you're in a larger practice, you'll show other people's things and they'll show you the things where you have expertise in it. And I think that creates some job satisfaction for sure, and helps with quality control because there's just too much to know like altogether.
Yeah.
I think. And so yeah, but
Gotcha.
hematopathology is kind of fun. I mentioned a bunch of things about it, but it kind of bridges both anatomic and clinical pathology because we do look at blood, bone marrow, body fluids, lymph nodes, kind of from a morphology standpoint, but we also do a lot of laboratory testing. And my favorite from my stem cell background and whatnot is flow cytometry, because flow cytometry is basically like cells are going through like little droplets, one cell at a time, but very fast. You might have like 1,000 cells per second, but they're all going through one by one through like the stream of lasers. And they don't avoid the lasers, they get hit by the lasers. But the way the light bounces off, you can say, okay, how granular is the cell? How big is the cell by its forward scatter? It gives you a bit of an estimate. And then you can put antibodies on there that are linked to various fluorophores. And so, you have different lasers they'll emit like a certain wavelength. It's like, okay, that one had a FTSE molecule on it. We know it had CD45. It's a blood cell molecule. But all this is very worked out. And so you can really know exactly what cells you're dealing with just on a 1-by-1 basis. You can find a clonal B cell population, abnormal T cells. You can characterize a blast population to diagnose acute leukemia. And this is done like in minutes, basically. So you have this, straight from the body, fresh tissues. And then, of course, from the research standpoint, what is cool that you can do is basically as those cells are flowing one by one through, you can mark the cells that you want. You tell it, okay, anything that has this particular features to it, I want you to sort that into a little container, and I'm going to take that to study
It's
some
just
more.
the only thing I can picture, I don't know if you've seen these videos, I would assume you've had to, are like the like the tomato sorting machines that the tomatoes are going down, and if the red tomatoes go past, and then if it's a green tomato, right, it's not ripe, then there's like an air jet that will push that tomato out. I'm like,
Oh,
what you're describing is exactly
it's
that. It's a
basically like, I actually
tomato
haven't
sorter.
seen that, but
I'll send you a video.
oh, excellent. I definitely need to jazz up my talk. So I definitely got the tomato sorter sounds. That
It's
sounds
amazing.
amazing.
Like, do you think, I mean, as you're saying this, I think about, like, do you think we'll get to a point where we'll have enough of that ability to basically do dialysis on someone, and all of their blood is going through a machine for 24 hours, 48 hours, whatever, and we're going cancer, 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 kick it off, kick it off, kick it off,
You know, just
and
remove. Well,
we're taking it all out, and then like, how awesome would that be?
yeah, I don't know if that would be cured, but we definitely do that. Like the cytoreduction, reduction, we definitely do that.
Okay.
To remove, like, people have so many tumor cells, like they're just getting clogged. That's like a first step. You can kind of take those cells out of the blood.
Yeah.
So yeah, so
Better
that's
than
definitely a
just
thing.
regular old bloodletting.
Yeah. Yeah, not right. Yeah, it's like a slight advancement over the regular bloodletting. So yeah, no, it's kind of funny. There's so many things that actually be in the realm of stuff I should do, but I actually don't do even those things. Like, because I'm just even more so specialized, and too so specialized probably. But yeah, so that's kind of the basic thing. My path. This is me. I did a chemical engineering of all things, which actually I really loved. But you wouldn't need to do that. You could just get a job after in chemical engineering.
Nice.
Skip the remaining odyssey. But I got really interested in kind of in metabolism and kind of the chemistry inside cells. So I think it was useful. I ended up going to England. I was actually in the MS research lab, and I joined a multiple sclerosis research group there for a couple of years because of my interest from my dad being sick. Was there, and then I came back and did my MD PhD program, and then I left off a few things because it sounded insane. But I actually initially decided not to do residency at all because I was really interested in research, and I went to MIT, and I was doing a postdoctoral fellowship there in mouse models of cancer.
Wow.
And then I kind of went the other way and decided to be a surgeon for about 3 years, and I did 3 years of urology.
Okay.
Came back and I was like, you know what? I really enjoyed it, but I'm really not a surgeon because I do spend too much time thinking about things.
Yeah.
And that's not good. No, yeah.
The
Yeah.
time on table is important, and
Time,
you can't like, you just stay here for a little bit. I'm gonna
time
go
is
think about
testicle.
this.
Okay. But I did really love it. But it was like, I don't know. I think that I just realized that, just took me a while to find a happy medium, but pathology is really where I belong. And so that's no one would need to do all that. But I definitely think it made me a better pathologist in many ways, having that clinical experience, even though they kind of eliminated that from the training because it makes it too long. But I think there's really, having the regular internship and just kind of handling things on your own in the hospital as a resident and as a surgical resident is a different experience. But so that's me. But this is why I was like super excited to finally finish and move on from the odyssey of all that. But it was good. Yeah.
All right. So I'm gonna steal screen share here for a minute, and I'm gonna see if I can do this. Let me see. I found an advertisement for a tomato sorter.
Oh yeah.
That is hilarious. And so it's showing you slow motion. That's full speed. And then here's slow motion. And then see, there's a green tomato that comes through here. At some point, all of these individual things are little levers. So watch this tomato there, and boom, it gets kicked down.
Oh wow. Okay.
I don't know if you saw that. Did you see that? Watch this little tomato at the bottom. Where'd it go?
This is really, I've never watched this before. Poor green tomato. I mean, I think it still tastes okay.
Oh, they're just one just got kicked. Oh, that's so fun.
So the green tomato would be like your stem cells. So you're like selecting the because the other
Exactly.
ones you're just letting through. So that's actually the special ones. So they
Yeah.
shouldn't feel bad. They're actually the love. They're actually getting more love than the other cells.
So I don't know if you can see my mouse, but each of these, can you see my mouse?
Yeah, we can see
Yeah.
it.
So
Yeah.
each of these little things is a little finger, and the lasers figure out like, is this tomato good or is it bad? And then the finger will just pop out and kick it down. So like you'll see, like
Oh,
that's full speed.
yeah.
And you can just see the fingers just going like that's what your machine's doing basically.
Hopefully they're landing on something soft. All these poor tomatoes are moving so
Oh,
fast.
look, there you can see it from this angle. Boom, boom. Like, oh, that's so
Oh,
cool.
they're in the water. Oh wow. Oh, okay.
Yeah, they're going into a bath, and then all the rejects get shredded or something. I don't know.
Aw.
Anyway, you can share yours again. But that's what I thought about. And so there's a potential visual you can use in the future.
Absolutely. No, that seems fun. Yeah, so sometimes we have like people come like, rotate through and see what we're looking at. And sometimes when you're looking through the scope, especially sort of like I actually do ice skating a lot. And when you figure skate, like when you first learn how to spin, you get like it takes you a while to learn how to spin and not get dizzy. But
Yep.
you usually takes long enough to figure out how to spin in the first place that you kind of gradually get used to it. But what's worse is like staring at cells in the microscope. Like nothing makes you more nauseous and tired than that.
Yeah.
So we have students come through and they're like, oh my God. But it is actually like, if you bear with it, you get used to it. It's like you just,
That's
you train
interesting.
yourself to not get.
I've never thought about that, because your eyes are perceiving motion, but you're not moving. And so it's almost like virtual reality motion sickness. People that don't like. Oh, that's interesting. I never
I'm
thought
not
about it
sure
that
if
way.
everyone has. I definitely really noticed that when I first switched over to pathology. I was like, oh wow, especially because when you're a trainee and you're not moving it, like when you're the attending and you're moving it around, it's really
Yeah.
not as a big a deal. But when you're there for hours and someone's like, oh, please stop, and you're not quite in focus and you're trying to like, I don't know. But yeah, I guess a lot of it is also transferring to digital, which I think is easier for people to see too. Some places are actually all digital.
Wow.
Hempath is a little bit difficult because we're usually looking at very high power, and so then the files end up being huge. And there's particularly with a bone marrow aspirate, you've got different levels that you kind of want to scan through because you're looking at the whole cells. So it's kind of hard to scan. But I just want to show you some examples. So I think it is quite beautiful. Like once you get used to like looking at it. This is a peripheral blood smear. And so we can see like the red cells in this particular case are actually have what we call quite a bit of anisocytosis. There are quite a bit of different shapes, and different sizes. And so this is like almost like a teardrop, but some are kind of a more elliptical, but they definitely have a range in size and appearance, which tells us there's something going on that's probably affecting these cells. And then
What are those
this cell,
spiky ones? The
little
spiky red blood cells.
little spiky cells. Sometimes they'll look when they're more fragmented, some of they look interesting, like look like a little bunny rabbit or something like that. I should have I should have shown.
Do you follow the pathology, I think, Instagram account where they take pathology pictures, like a slide like this, and then like, oh, look at the shape that I found here. It's almost like looking at clouds going, oh, look at the shape of that cloud. Do you know that Instagram account?
I don't know them, but yeah, people do that. Yeah, no, like they'll collect the whole alphabet and they'll collect different, but the shapes are kind of fun. I did have one that looked like a rabbit. I should have included that. Yeah, this is one of these hyper-segmented neutrophils that you can see in megaloblastic anemia. This person, yeah, they have some more complex things going on, but that's one of the things you can see there. That's one of the things we look at. Let's see. I was also going to show, this is the bone marrow, which the bone marrow aspirate is pretty interesting. So because this is where all of your red cells, all your white cells are being born. All your platelets are coming out of these megakaryocytes, which are very large cells. Basically, bits of their little cytoplasm comes off and becomes the platelets that enable blood clotting, or that are part of blood clots. And they just live in bone marrow sinusoids and just kind of release their cytoplasm until they're all gone. And then you got to get another megakaryocyte. They kind of give their give up their cytoplasm little bits by bit to give you platelets. But yeah, there's kind of these spicules that are generating all your blood cells all the time, and it's kind of quite extraordinary, like the process it takes to make, like, here's one neutrophil going from a blast to these more differentiated forms to finally get you that one neutrophil to go circulate around. And red cells similarly go through a whole process of multiple divisions. And so we kind of look at that and see if everything's going on in an orderly fashion, or if these cells are messing up. Like sometimes they look like they're really malformed or something like that, or they, what you call dysplastic, or, do you have like an arrest at a certain stage of development? Like this is a blast. And so like in acute leukemia, you'd see like a whole pile of these accumulating, and they may look atypical as well. And so that's kind of what we do, looking at those. And we also look at the core biopsy. This is just a little core from someone's iliac crest, looking at the bone marrow, just kind of a normal bone marrow, these little pieces of fat. And the amount of fat, which are these white spaces here, kind of increases with age, which is normal. But I showed all these cases to my mom, and my mom's like, "You're saying even my bone marrow is getting fat?" It's like, "Yeah, mom, your bone marrow's getting fat." But we just don't need as much hematopoiesis as we get older. Like, so if you look at a young child, it's nearly 100% cellular, and then getting to around 70-80%, it's 20 to 30% cellular. And these are just little adipocytes that are basically removed with processing. We don't see these little fat areas. These are megakaryocytes, and these really dark colored ones are erythroid elements. And then we've got neutrophils. So all the stuff is kind of going on there, and you just kind of want to see a happy, heterogeneous environment. But there's a whole number of ways, particularly because these things are dividing all the time. They could be under high stress formats. You could get various translocations or things like that. So we're always like keeping a close eye on those. And people come in, maybe they have an abnormal serum protein, maybe they have anemia, maybe they have low platelets. And so this is one of the things that we look at. It's an abnormal bone marrow. Some of these cells have some vacuoles in it. It's not the prettiest look. It's kind of characteristic. It doesn't always look super pretty. And then this is the core biopsy that went with that, which was elderly gentleman. And this is like really, really hypercellular. You can see these cells look pretty weird. These are atypical erythroid elements that are all in here that are kind of, we call left shifted, because of the way our we kind of have a little tick thing, like ticking through like what cells are what, just with your hand as you look through it. And so you're shifted towards the left. They're more immature. But yeah, so those are things we kind of look at. And we look at lymph nodes too, which is kind of gotten a lot of interest with COVID, because everyone was getting these swollen lymph nodes, and they're like, some people had swollen lymph nodes before, and they didn't notice them, because you just don't necessarily notice. And I think we don't necessarily know, but it just seems like some of these lymphoproliferative processes may have been exacerbated also by COVID infection. So we got a lot more lymph nodes to look at during this whole craze, because people got, and then, the COVID gets better, and they're like, well, I still feel my lymph node, I think. Yeah, and then normally lymph nodes do get big when you get an infection. You have these kind of B cell follicles here, which are these pale areas here, where you get kind of antigen recognition, and you get selection for particular B cells to make antibodies against a particular antigen. But as you can envision, this process could get messed up in a variety of instances, where you've got cells that are rapidly dividing, responding to antigens. They get some sort of mutation or translocation that allows them to, kind of just grow more than they're supposed to in that context. And T cells are also stimulated in this process, and can also, potentially result in various tumors as well. And of course, you can get weird infections and stuff in there too, other than COVID. This is an example. For example, what can happen. Actually, we see this not totally infrequently. You get real thickened capsule, kind of a lot of plasma cells, and some reactive germinal centers. This is a particular example actually of syphilis that can happen. You kind of get like a matted lymph node. This is a nerve that got trapped in this mess here, some blood vessels and nerves, and then a really thickened kind of lymph node capsule. And you don't really know what's going on, and people like have this persistent node. Could be even Hodgkin lymphoma. Turns out this case, fortunately, was just syphilis, so treatable at least.
Just syphilis.
Just syphilis.
Syphilis.
I mean, in terms of, yeah,
Yeah.
it's not good, but it's treatable.
Yeah.
Usually.
Yasmin asks if these are all H&E sections.
Oh yes, these are all H&E sections. These particular ones I'm just showing. This is one that we like to make a diagnosis, kind of just a reactive condition. But we get these kind of, we call them hyalinized follicles. These are basically a B cell follicle that has a bit more sclerosis in it, and then we get these kind of sclerotic vessels and kind of these, we call it onion skinning around them. They're mantle zones, and then this kind of, we call it like a lollipop look to it. But it's typically if isolated to a single part of the body, is typically a benign, self-limited process. But
It's funny you have that specific disease on there, because I've talked to Dr. Feigenbaum before, who's
Oh,
the
wow.
doctor. I don't know if you know him. He's the one who like cured his own
Yes.
Castleman disease by figuring out that there's this treatment out there that cures it, or at least stops the process or whatever it is. So it's funny you have Castleman on there.
Yeah, Castleman disease is relatively rare. It's super interesting. So you could have unicentric Castleman, where you have just like, one kind of, oh, I noticed this big lymph node, or they'll notice like a big node on a scan or something, and they'll take it out, and it might look like this is hyaline vascular variant. And it seems to be an inflammatory process. And if it's just in like one location, then it tends to be self-limited, but you can get a more systemic version of it that can be extremely aggressive and just kind of causing like a cytokine inflammatory storm, and it can be very dangerous. And it's not a tumor per se, but that doesn't really help you. Some of them can be driven by viruses and some of them are not.
Yeah.
But yeah, Dr. Feigenbaum has done some really fascinating work and raised a lot of awareness of this issue. And yeah, now we actually have some drugs that can modulate kind of this inflammatory storm, and save people. But yeah, he's amazing. So yeah, yeah, he's definitely one to have on this show.
Yeah.
Yeah.
I just posted a link for everyone in the comments. I had him on the Premed Years podcast. So
Oh
it's a
yeah,
good conversation.
He's fascinating. Yeah, this is another example of a benign lymph node, but definitely a pathology that you'd want to recognize. We can see here that there's basically, these things aren't very well defined, and they look sort of cheesy, maybe you could use that word. So yeah, this is all necrotic area here, and then we've got some lymphocytes that are here. There's some reactive lymphoid cells left. There's a lot of histiocytes kind of in there. And then looking closely, they look a little like, here's the nuclei of the cells, but then there's these weird things. So hematoxylin and eosin, the hematoxylin is the blue and will stain nuclear material. So there's some other thing in here that's got like some nuclear material, and the eosin stains pink. It stains more proteinaceous stuff. So there's something going on in this lymph node. And it turns out it's histoplasmosis. This is the silver stain, which will stain these fungal walls really nicely. So you're like, oh yeah, okay, wow, okay, yeah, there's a lot. Because then this one, you're like, I think I see something there that looks a little weird, but we use special stains so you can kind of really highlight that. And this is actually a right Giemsa stain too, where they show up much better than they do on the H&E stain. This is a kind of a touch imprint of the lymph node, sort of like using the lymph node uncut section to make like a potato print, and then staining it. We like to do that because it looks kind of cool, and it can be in some cases diagnostic. So yeah, I don't know.
Hadley
So
says pathology looks very confusing. I'm assuming pathology very similar to neurology with like EEGs, where it's just a bunch of squiggles. Like once you understand what you're looking at, then it's like you understand what you're looking at.
Yeah. I mean, just like anything else, and we start, well, certainly in medical school, we have all kind of the normal histology, like just getting used to what are the cells here, what is the normal pattern that they should show, and how does this process deviate from that? But a lot of it's just just repetition, and the findings may be kind of vague and non-specific when you see them by H&E. And so if you don't really know what you're looking for, like this one, I don't know if you'd miss or not, because it's just so profound, so much fungus stuff in there. But yeah, but like certain things you may see a subtle finding and think, oh, yeah, okay, I think this could, based on their history, I know they were hanging out in, a certain environment, or I know they're on steroids, so they may be immune suppressed. So I'm going to look for fungal elements. And then if you stain them, then you're like, oh, that like it jumps out at you. But just, I think a lot of it is just getting the experience of looking at zillions of these cases and getting burned a few times. And you're like, okay, I'm not going to miss that again. Like I'm going to know it the next time I see it. But yeah, I spend a lot of time reading through the medical record, making sure that I really understand the patient's history and that there's nothing else that they may be at risk for, or they may have a history, that may increase your idea that they, could be at risk for a certain thing that, we have all kinds of interesting tests to do, but you can't certainly do all the tests, and you shouldn't do all the tests on every specimen. So to kind of make sure that you're using whatever limited material you have in the best way to get to somewhere diagnostic is the key.
Yeah.
But this is another one that we see. This one is our, kind of one of the most frequent diagnoses that we make, particularly in young people, is classic Hodgkin lymphoma. And they have a very characteristic appearance, like on a cut section, but this is how they look. This is a touch imprint where you get these big Reed-Sternberg cells. And so you see something like that in a lymph node, you're like, okay, that's not normal at all. And then it tends to be surrounded by kind of a mixed inflammatory environment, usually with the eosinophils, which are not in this picture, but there's some plasma cells, little plasma cell guys here in the background, and small lymphocytes, and then these big atypical cells with so-called complex nuclear features and these very prominent nucleoli. But you just never know what you're going to find, like, because people usually, maybe they just discover they have adenopathy, maybe they have fevers, maybe some people end up having, nothing wrong with them, or they have, nobody told you, but they just adopted a whole pile of kittens and they've got cat scratch disease or something.
So you're saying pathology is like a box of chocolates. You never know what you're going to get.
Yes, it's like a box of chocolates. I mean, yeah. And I don't know, maybe chocolates, you don't want to be interesting in general. Yeah. You want to just find the caramels in there and just, yeah.
Best.
And there's another one. This ended up being a large B-cell lymphoma, which typically would have sheets of cells, but this is a particular kind that's driven by Epstein-Barr virus. And so just the tumor cells are these large guys here, which are kind of in a mixed inflammatory background as well. But obviously it's hard to necessarily get to that diagnosis on a potato print, but
wow.
We had some more stuff, but yeah, oh yeah, and this is sarcoid. So this is a touch imprint from, so you get in sarcoidosis, you get these kind of so-called epithelioid histiocytes and kind of these granulomas. These are just kind of piles of histiocytes where you don't have the necrosis, like the necrosis that we saw in the other one. Is typically associated with more infectious processes, and then, or even Hodgkin lymphoma, but these kind of really nice, well-formed epithelioid granulomas in the absence of infection and with the right clinical history and all that stuff, it's very suggestive of sarcoid. But yeah. I think it's cool. We see a lot of really interesting things, and this person is very nervous. What do they have? What's this? And then you're just like, you put out this is what you have. This is, and then so they know the right treatment and everything to give them. Sometimes, I mean, our reports are not always definitive, of course. Sometimes we don't know when we ask for more material, or we say it's confusing and everyone gets mad. But you don't want to tell, you're not always sure.
I think that kind of going back to the earlier question of like misconceptions in pathology. I think one of those is that maybe dissimilar to dermatology, where a lot of dermatologists can look at something and go, I know what that is, right? In pathology, it's not the same. You can see potentially very similar findings in a stain like this and go, well, as you just mentioned, is there an infection? Is there not an infection? Is there this? Is there not? And it's several steps of trying to understand what's going on for you to finally get to, okay, well, I think it's most likely this thing.
Yeah, and I
Right.
think some things are particularly complicated because, for example, you could have, because it's a tumor, you could have a tumor that's of the immune system. And so by nature of that, it's maybe altering your immune function.
Mm.
And so then you've got somebody who's got not only a tumor of their immune system, they also have super infections because their immune system isn't able to fight stuff. So there may be reactivated viral things, there may be bacterial processes, other things that are going on in the background, particularly with T cell lymphomas. They can, particularly like angioimmunoblastic T cell lymphoma, can create some diagnostic challenges because you kind of have these atypical T cells are in a mixed inflammatory background, and they also are immune suppressive. So you can have like a clonal B cell population crop up as well because it's just not being controlled by the T cells, particularly with viral reactivation and things like that. So you have a very kind of mixed picture going on, and so the people end up with some, you know, sometimes it's very clear, but other times you end up with, well, we're getting some clonality studies and different things, and maybe even some molecular studies to make sure, because you don't want to tell someone, oh, you've got a T cell lymphoma, and they don't, they just, got kind of run down and, mono reactivated in that context or something like this. So yeah, I don't know. I think it keeps us busy for sure.
Yeah. What does work-life balance, if there's such a thing, look like for you?
Think I'm not very good at that. I don't know. I mean, I think that's one thing about pathology. I think that it can vary quite a bit. And like, I think if you're in a more clinical setting, it's like there's going to be a perception of, you could see, this, you can't see 400 patients in one day. That's not going to happen. Like, you're going to be able to see 10 patients or X many patients, and you're going to have a clinic day and a non-clinic day. In pathology, we don't, like, the cases differ quite a bit in their complexity, and each individual specialty, also the cases differ in the amount of time it takes and the amount of complexity. And there's no real, like, saying like, okay, you can look at X many things per day, and that's considered a full day. So I think, yeah, I don't know. In short, we're pretty busy, and I don't think I have a work-life balance.
Yeah. Do you see, I know there's always talk of kind of machine learning, AI. I know Google's very involved in this world. Do you see that not necessarily replacing pathologists, but helping you get through more cases, maybe just be more efficient? Is that happening now, or
I
do
think
you
it's,
see it happening soon?
yeah, no, that's like kind of one of the most exciting aspects of our field, I think. Obviously when I look at a specimen, like I look at this sarcoid thing, like I'm getting what we like to say in medicine, of course, like this word gestalt. Like, you're like, okay, I see some small lymphoid cells, I see, kind of these cells that are more adhesive in this pattern. But there's probably like other things I'm looking at. There's a bunch more patterns that I'm not seeing.
Mm.
So, artificial, and sometimes takes me a long time to get to a diagnosis. And so, maybe there's certain things, like if I fed in all these cases of a particular type into an algorithm, like you could scan the things and it could find things, maybe it's looking at chromatin clumping and cell size or nuclear membranes or God knows what. Like, there's, maybe something that I didn't even bother to, that my brain just didn't even register. Or maybe it's looking at blank spaces or something, like the cells have some, I don't know. So all that stuff could get fed into an algorithm. So whereas I, do my best with what I've got, then I feed it into the algorithm, and the algorithm's like, hey, you know what, other things with these features, all these people had syphilis. And you're like, oh, I didn't even think this person would have syphilis, and so then, I think it could really enhance
Mm.
those type of things, because this, once you had developed these algorithms, it could run in the background,
Yeah.
or, looking for small metastases and things like that and nodes. So, and because we can now scan all these cases, we can easily feed them into various, these digital files could easily go into various algorithms. So
Yeah.
we'll see. We have a person that we've hired here, Human Rashidi, who's working on that. People working on it at multiple institutions, though, but it's definitely a push from our department to kind of think of ways that we can do this. I mean, yeah, maybe it could facilitate sign out, but I think it could also facilitate just making sure things aren't missed, or as a quality control measure and other things. But yeah, maybe eventually it'll just be totally replaced by a robot.
The machines are coming for the jobs. Well, Dr. Genevieve Crane, thank you so much for taking some time with us today to share your field of hematopathology and all this beautiful art. My one last question.
Okay.
Do you have histology art hanging in your house?
Oh, well, I do
Not
have
in your
histology.
office. The office
Yeah.
doesn't
Oh, in the
count.
office, I've got one right over there. I love my histology art. Yeah, I have some. Various pictures of the bone marrow. Also artist renditions of the bone marrow, in addition to actual pictures of the bone marrow. We've got all that stuff.
Nice.
Would you? I don't know. Yeah, maybe that's weird, but I
don't think so.
Even the normal histology. I think the normal histology is very interesting and very beautiful, particularly when stained. So
awesome. Well, thank you for coming on and sharing, taking some time out of your day.
thank you so much for having me.
You're welcome. Goodbye, everyone. Thanks for coming.